Hi, good evening. So this is the third episode of our WIGIL webinar series on the one case that taught me the most. When I was thinking of appropriate cases for this title, I found myself thinking that choosing such a significant case really needs to draw from a lot of clinical experience and like a reservoir to really be worthy of that title. Being at a relatively early stage in my career, I thought perhaps a more appropriate thing at this point, because I'm sure I have lots to learn in the coming years, is that I'd like to talk about a case that taught me a lot as opposed to the most. So, my name is Dr. Gayatri Balachandran. I finished my super specialty in surgical gastro, and I'm currently finishing a fellowship in liver transplant in Chennai. So, if Dr. Monica is okay, I can start, or would you like me to wait for some more time?
You can go a brief, detailing if you want to, just how you come to choose this case and all those things. And then within 5 minutes, you can start,
Sure.
or 2, 3 minutes.
Yeah. So, I'd like to take you back several years ago, actually. So, this was about 3 years post my completion of MS. I was working as an assistant professor in general surgery in Bangalore. At that point in time, I was operating independently, mostly open. I was like, venturing into advanced lab like hernias, the odd fundoplications, TVGJs, and the occasional splenectomy. So that's when I was pretty confident, and I could do anything at that point in time, or so I thought. So that's the background of when I had this experience dealing with the patient and the fallouts of a surgery gone wrong. And in many ways it was life altering. It really put a magnifying glass, so to speak, on my experience thus far. It really showed me what lacunae I had, and I think in many ways it was one of the reasons I decided to go ahead with my aspiration to pursue super specialty, because I realized there's so much more to learn and perfect. So that's why some of the lessons from this case, most of the lessons aren't exactly technical or theoretical. So I want to give a disclaimer at the beginning. It's more of personal reflections and lessons that I learned, which have held me in good stead still, and hopefully will continue to do so.
Yeah, in fact, to add it up, I think the most important cases are those where we get stuck and we like try to get out those tricky situations and then we learn. And
Mm.
I think it's very humbling that we accept our problems in those cases. Otherwise it's very easy to say that yes, everything is right and we do 100% and all those things. But I think most of the foreigner present in a way that they try to discuss the cases with the real issues. They don't hide their negative points, isn't it?
Yes, ma'am. Yeah. So, Shruti, are we
I think we
okay
can
to start?
start. Yeah, we'll start.
Okay.
Thanks.
Okay.
Uh,
So, yes, Shruti?
were the introductions given? Sorry, I was logged out shortly. Okay,
No.
so okay, Okay, I'll introduce both the moderator and the speaker. Dr. Monica Gupta, she is a senior GI surgeon, and she is practicing in Jaipur in Narayana. I met her, I think, 12 years ago when I was still in general surgery training, and I was, attending ISG Con. So it's we are very happy to have you on board for this
Yeah,
meeting.
I'm at Manipal, Jaipur, right? Thank you. Thanks for
Yeah.
introducing.
Yes, Manipal Jaipur. And Gayatri is our very super and very special GI surgeon who's now gone into liver transplant, and she is training in liver transplant in Global Hospital in Chennai. So the stage is yours, please.
Thank you, Shruti, and thanks, Dr. Monica. So, for those who just joined, I'm here to talk about a case, a patient that I managed before I went into super specialty when I was a general surgery consultant in Bangalore. So, the patient in that we'll be discussing today is a young gentleman who was in the pink of health actually, and was diagnosed to have Evans syndrome, which, as we know, is a coincidental syndrome of ITP with autoimmune hemolytic anemia. He was on follow-up regularly with the hematology department in our hospital then. He had been through several regimens, including steroids, azathioprine, and rituximab, despite which his platelet count remained low and he was referred for a splenectomy. So, as I had mentioned in my background, at that point, I was, starting to do more and more advanced lab cases. And so our unit was covering the duty that day. And so the referral came to us, and I was thrilled. I'm like, of course, I can do it. I had done 2 or 3 by that time, and it had all gone smoothly. Patient discharged by the third day. So I was like, yeah, there's nothing I can't do. Of course, let's do the case. After all, it's just a splenectomy and it's just ITP. I mean, it is small spleens just waiting to be taken over. What could possibly go wrong? So I had, I knew the textbook description. I knew where to put the ports. I had done my YouTube research and seen videos about exactly where to dissect and where to open and where to get the vessel. So, I was ready. So textbook ports just above and to the left of the umbilicus is my camera port, everything as usual. And in I went expecting a smooth surgery out by 2 hours. But then I quickly realized this is not just another ITP spleen. The spleen was small enough, was not too bad, but I realized that my ports were absolutely wrong for that particular patient. He was a hefty guy. The supraumbilical distance was quite significant, and my my optic port was way too low. And so also my working ports. So I struggled to see over the hilum towards the diaphragm, and right from the get-go, I was having a lot of problems. Previously, when I had, started doing lab spleens, I had spoken to the professor and told him, sir, be around, I may need help. But by the third case, I was like, okay, I should be able to handle this. So that day, I hadn't really asked anyone to be on backup. I had final year's general surgery PG holding the camera and a nurse assisting. So there wasn't a lot of help or um, anyone around that I could really consult for. And truth be told, I didn't really think of calling anyone into the OT at that point. I thought, okay, let me just labor on. So I labored on. I managed to mobilize the lower pole a little bit, get some of the phrenicocholic attachments and diaphragmatic attachments as much as possible off, which wasn't much, to be honest. I'd opened the lesser sac and I could see the hilum. So I thought, okay, let me start. I mean, whatever's there in front of me, I'll start. So one lower polar vessel and vein done, all good. Okay, then I was advancing. And this was a hefty guy, a lot of fat. Thought, okay, let me keep going. But it was a struggle because I just couldn't get vision. It was tangential, and I can't blame the camera guy. He was doing his best, and hilum was a real struggle. And the next thing you know, there was a snap and a gush of red. It looked venous. Suction, 10 mm suction, whatever we could. I just couldn't see the bleed. So he started getting a bit tachycardic. BP was okay. And at that point, we just quickly decided to converted. There was a tear in the splenic vein. We controlled it, quickly got the spleen out, done in 2 hours. One platelet unit, one PRC, not too bad, patient stable. I thought, okay, crisis averted. We've salvaged the situation and we shifted him back to the ITU. The first 3 days was smooth sailing, recovering as usual, NG out, Foley's out, everything was okay. But the platelets refused to come up. I mean, hematology, the physicians would come on rounds every day and, they're looking for 6-figure platelets. What's happening? It's 20, 25, 30, not coming up, not coming up. So they put their heads together and they sent some tests, like what could possibly be wrong. And they found that his APLA was positive, a workup which I wasn't aware of, that had to or need to be thought of, and certainly wasn't thought of thought to be an issue at that point of time. If the patient was doing well, okay, maybe a procoagulant state, but patient is fine. Then from the fourth day, things started taking a turn for the worse. He started having some abdominal distension, was uncomfortable, tachycardic, blood pressure was okay, SATs were okay, but things weren't okay. So we thought of the usual differentials. There was no bleed, hemoglobin was stable, nothing in the drain amylase was normal, serum amylase, lipase were normal. There was no acidosis, venous lactate was normal. So we thought, okay, maybe some ileus, something. Let's just wait, support and see. And we waited. We waited for another 48 hours for him not to settle before we did a contrast CT. At that point of time, we found that there was thrombosis of the splenic and superior mesenteric veins. Proximal small bowel was edematous, not enhancing very well. There was no free air, but there was definitely venous mesenteric ischemia. And by that time, he had clinically deteriorated, respiratory distress, vasopressors were initiated. He needed to be shifted to the ICU and was soon intubated thereafter. So there was no question. We're dealing with the mesenteric ischemia with sepsis. He needed an urgent laparotomy. So at laparotomy, there was multiple, it wasn't fulminant gangrene, but multiple areas of patchy gangrene of the small bowel, starting from around 20 centimeters from the DJ through to the ileum, leaving about 100 centimeter segment that was relatively uninvolved. So we resected. And at that point of time, my HOD was there on table as well. We decided, this was a seasoned surgeon, and in his judgment and in our judgment, we felt that 20 centimeters was just too short to bring out as a stoma. There was no option but to anastomose. So we anastomosed primarily. At that point, he wasn't on very high supports, maybe a few ml of noradrenaline, but not very high. So we thought, okay, young guy, otherwise, okay, let's take a chance in anastomose. And we planned for an elective relook after 2 days. He was in ICU, managed, supported with parenteral nutrition. We started him on anticoagulation. And at relook, everything seemed okay. Bowel was pink, anastomosis was okay. So we extubated him and he was soon shifted to HTU. But this respite was very short-lived. Soon after the re-exploration, he started having SIRS again. He started desaturated, had to be re-intubated again. And lo and behold, there was an anastomotic leak with a collection around the anastomotic site. So we took him up again. Again, it wasn't a complete dehiscence, a partial dehiscence. So we redid the anastomosis. Even though there was only 100 centimeters, we put a feeding tube into the distal limb in order to be able to give him some form of enteral nutrition. And then as the days passed, the next 3 weeks were very, very harrowing. Everything just leaked, that nothing was holding on the bowel. Soldering sepsis just kept continuing. He needed a total of 5 relaparotomies. So at various stages, various strategies were employed. We consulted with multiple surgeons in the other units. We took in a lot of opinions. T-tube into the anastomosis, drains for drainage, for exteriorization of the leak. We tried an endoscopic NJ tube across the anastomosis to vent it because, nothing was, we're talking about 2 liters of bilious effluent every day, started coming out through the wound. So we opened out the sutures, managed it as a laparoscopy with rack. At one of the re-explorations, the proximal stump was intubated and we closed around it like a purse string. We also did a tube gastrostomy in an event with the idea of venting the proximal secretions. At another re-exploration, that stump had completely blown out. We managed to close the proximal stump this time. Another re-exploration, the tube ileostomy site was leaking. So it was a mess. We were just unable to contain enteric contamination, and the patient just continued to deteriorate, high volume leak, persistent fever. And by this time, the patient's family was struggling to cope with the financial situation, and they had to ultimately decide not to escalate, not to resuscitate. Patient still labored on for another 7 days at this point, and then succumbed. So this was the case, and I've had many years to reflect on it. It's one of those things that are etched into your mind that face those events. And these are some of the lessons that I have drawn from this particular case. So starting with, the reason we operated. I feel very ashamed to say this at this point, but at that point I was like, okay, the experts have told me he needs surgery. Okay, I can do the surgery. They need it, we'll do it. I think no offense to any physicians who may be listening or any physicians. I know you know your job, you know when it's required, but I think most important dictum is you must be aware of the need for the procedure you're doing and you must be convinced of it yourself. Only then can you take on full responsibility for your actions and the fallout, if any, after the surgery. So I think at that point, I wasn't aware. I didn't know much about it. I knew, okay, the basics. This is when you need to operate, this is how you operate. But whether it should or should not be done, whether any additional considerations need to be looked at, I didn't know. And definitely, despite low platelets, to have such a procoagulant state with the underlying positivity of the antiphospholipid antibodies must have contributed to this case. I didn't know that need looking at whether it was even a consideration, and that was a big problem in this case. And as far as operative surgery is concerned, yeah, I knew how to do it. I've done it before smoothly with no problems. But in this particular case, with this particular patient in mind, I was not prepared. I hadn't had a plan in mind. I think that was a novice's mistake. Applying the same fixed model, the same fixed checklist for every patient without adapting, that is a mistake that can be made early on. But I know that after this experience and other experiences that I approach things differently. But definitely that was a problem which led or maybe started the domino effect in this patient. After training with Dr. Sikora, we encountered a similar situation. I'm not sure if sir remembers a lap spleen, much bigger this time, where there was a tear in the splenic vein, but we were able to manage it because the approach is completely different. And I realize that now, diving into the hilum without establishing visibility, without mobilizing the spleen completely, that leaves you with very limited options if you encounter a problem, which is what happened to me. So in that case with Dr. Sikora, we had already mobilized widely. He was able to lift up the hilum. We were able to establish some sort of control for us to be able to clip and take down the splenic vein, which in this case, I was completely and utterly unprepared for. And remember, YouTube only shows you the good stuff, the awesome stuff, the perfect surgeries with zero blood loss, with no intra catastrophes. No one tells you how to manage a problem. I think that's where the wealth of experience comes in. And I know, again, not to say that it isn't a valuable resource. Of course it is, but it should not be your only go-to when you're dealing with a new surgery or a relatively or procedure you're relatively inexperienced with. And always have help handy. I regret not having, had some backup that day. Maybe we could have tried to salvage it laparoscopically. Whether having finished it laparoscopically, could I have averted this tragedy? Could we have prevented the problem? The procoagulant condition was there underlying. I mean, it's a question that I'll never know the answer to. It's something that I've always pondered. What if his referral had gone to another unit and someone else was able to finish it laparoscopically without a problem? If I had some help that day and we could have handled the situation differently. So this is another learning point. And as far as the complications, I think there was a delay in diagnosis, maybe because I didn't know to look for it. We did the basic workup, venous lac rate was normal. It was like, okay, tick, this can't be mesenteric ischemia. But subsequently, as I've learned and seen in so many patients, every patient doesn't need to have all the criteria. It's a gray area, and the importance is early detection, early diagnosis. Could we have revascularized him? Could we have initiated anticoagulation early and averted full thickness gangrene? Definitely, the delay may have contributed. And again, a lesson I've learned during DNB with Dr. Sikora, mesenteric ischemia, primary anastomosis, generally no. stapling and cleaving it, as was the preferred protocol in our unit when I trained. There are other options that should be considered, because inevitably the ischemia progresses and you're dealing with disaster if it leaks again. So obviously, redoing it is also a bad idea. Then, as far as the ways we were struggling, I think we just struggled to catch up with a problem that had already gotten ahead of us, out of our control. The more we meddled, the worse the situation became. So I'm not sure at this point we can discuss other things that could have been done, at not to prevent, but to deal with the disaster that we were dealing with. But maybe too much meddling just helped make things worse. So I'm not sure if it's exactly a switch stage, but I think a lot of things aligned to allow this patient to deteriorate in such a fashion. We hadn't really understood the pathology that we were dealing with preoperatively. We were a relatively inexperienced team dealing with what we thought was a routine procedure. The delay in diagnosing the complication post-op definitely contributed to his deterioration, and possible errors in further judgment. Again, not to take anything away from the team that I worked with or the other surgeons in that institution. We were dealing with experiences we had and applied to this particular situation. We were dealing it the best way we could, but we were unable to salvage the situation. So, like I said in the beginning, I learned a lot from management clinically, but beyond the clinical realm, there's a lot of pearls that I picked up with this case, which I carry with me, constantly, and I will continue to carry with me. One of the main reasons I wanted to do super specialty was I wanted to not be scared of operating, but still be fearful. I think it's very important to be fearful and not overconfident that nothing will go wrong, fearful of what can go wrong, what could go wrong, and how not to let it go wrong. So this is a book that I fall back onto. It was one of the first books my father gave me when I started surgery. Those who haven't read it, please do. He says, if you're not a little afraid when you operate, you're bound to do a patient a grave disservice. Thankfully, in this case, the family was extremely understanding. They were not aggressive, they were not accusatory, but handling expectations was extremely difficult. Here was a young man, 20 years old, a child actor, if you he just happened to be. He was relatively well. He only had low platelets, the occasional epistaxis, and from a patient, for a family to accept such a deterioration was not easy. So I taught me the importance of complete transparency with patients. We often feel, okay, we shouldn't tell them too much. What if they run off? But I think you need to tell them what absolutely needed to be known. There's no point keeping it away, and that transparency only strengthens your relationship and rapport if things do, take a turn for the worse following surgery. One of the most difficult things for me to deal with was this failure. I mean, everyone says if you don't have complications, it's because you're not doing enough. But what happens when you get the complications? How do you get over it and keep on, working? It took me a long time to get over this. I would refrain from doing any major operation or anything a bit tricky. I would stick to the routine, the mundane, if you will, because I didn't want something going wrong, and I wasn't sure if I was competent enough to deal with it. So it took a lot of support from friends and families and small baby steps to regain confidence. But I think this is an important aspect. There's data to show that, there's significant, it's obvious, but there's actual data to show that, complications can have significant psychological impact on surgeons, and we need to be able to talk about it freely so that we can learn from our own and others' mistakes, and not without judgment, without fear of disapproval. So this was a real experience for me in that way. Regaining confidence wasn't easy, but one of the main things was understanding where I went wrong, what I needed to rectify, what knowledge needed to be gained in order to prevent such a thing happening again. So again, perfection might not be a reasonable ask, but we should always aim for it, even if we can't achieve it. So that's where this concept of a knowledge gap is what I understood, that, there were things that I didn't know. And again, this is one of the, not the only reasons, but one major push that led me to want to specialize further and train more. I'm not saying that everyone needs to do MCH and, general surgery is not enough. I'm not talking about formal training or a course. Even if it's one particular field or one particular procedure, there's always room to improve and learn more. Some of you may be aware of this psychological concept of a Dunning-Kruger effect. It's where you overestimate those who have lower competence tend to overestimate their own abilities or competence. So I think I was somewhere here around peak of Mount Stupid there. I was doing things on my own. I could do anything. I was on top of the world. And after this case, I was pretty much here. But that's where I need to gain competence, gain knowledge, and regain confidence. Never as high as before, but enough to keep going on and doing justice to your patient. So what this one case taught me, if I had to sum it up, it was a harsh reality check of my own limitations, what I could and really couldn't do, and what I needed to do better. There's no such thing as a small case. Every case needs preparation, and every case needs planning, and it needs the proper team, the proper backup. Every case. There's no such thing as routine. Routine can quickly spiral out of control and become critical, as you can see in this case. So anticipation is crucial, and there's always room to better yourself, to recognize where your lacunae are and overcome them. Dealing with complications, it's not something that you just shrug under the rug and just carry on, you and soldier on. It needs attention, it needs support, a great deal of strength, and self-reflection. I think that's key. Thank you.
Yes, Gayatri, it was a few comments are there in our inbox also, which I've gone through. And I think it was a very fair retrospective analysis of your case. And I think at this stage, if you're able to look into the retrospective points and you are ready to reanalyze, that is a main point which makes us learn. So I think it was a worth sharing case. And I like the co-hosts also to, keep discussing in between if they can unmute themselves. So a few points we may discuss with each other in this, right? So in the technical points, like as you said, that it was a hefty patient. Now, after so much of experience with that point, and you have been thinking about it, so what changes you will advise the junior surgeons to make in a hefty patient or obese patient in laparoscopic splenectomy? Any suggestions or anything?
I think, yeah, in terms of port placement, one positioning, make sure, especially in these smaller spleens, make sure you have a good lateral, almost lateral, maybe not just a sandbag, but a good positioning, almost lateral positioning for these smaller spleens. That will definitely improve your visibility. Port placements closer to the costal margin, not just near the umbilicus. Their distance should be counted into. They say straight line. It might not always be a straight line, but definitely closer to the costal margin than what is usually recommended. So then, of course, longer ports, longer instruments to be able to reach all the way to the suprasonic, that diaphragmatic area, and do your mobilization well. Good energy devices. We were using a lap harmonic on its sixth use, I think. I mean, something like that. So, like I said, good preparation and anticipating issues. So these are the issues I think that came up for me. And if I were to have done it differently, these are the things I think I would have addressed.
Yeah, I agree. Lap harmonic is okay even after 6 years. I don't think that is
No,
an issue.
I'm just saying six is just, yeah.
And another thing is like supraumbilical port should be placed, main camera port. position can be absolutely 90-degree or maybe
Mm.
more than 45-degree or 45-degree absolutely, with a table tilt as well as the sandbag and all those. Fairly placed. It should not be a formality. Then
Mm.
only. And important is that obese patient with small spleen. That is a very bad combo actually. So in
Mm.
ITP and all immunological diseases, they are not very big spleens. So that is the
Mm.
main. And another point is in the literature, ligashore itself alone has also been quoted as being sufficient for splenectomy, maybe it for trauma or any other reasons. But ligashore has been appearing in the researches as well that it is sufficient to coagulate the splenic vessels at the hilum and all these things. So I think that is an important point. So how low platelets have you, as you have mentioned, 30,000. So how much low platelets have you encountered in splenectomy cases? Till now? I mean, any of you, like, if you've heard about it, how much low it can be done?
The lowest I have subsequently seen with the teams I've operated been about was, I think we've done for 20,000, but I'm not. I'm sure people have done for less. Maybe other opinions can be um, welcomed because I've not done much after that because I've been into training. So maybe some other opinions to answer
Okay,
that
fine.
question.
I'll add to it. Like we have done at 1,000 platelets, but it was a very chronic ITP case, well managed with the hematologist's advice, and they referred to us. But we had to arrange SDP and transfuse just exactly preoperatively.
Okay.
So that was like lowest. And another point I have mentioned, I have like tried to discuss here is, uh, see, your case had a difficulty of coagulation issues, right?
Mm.
Prothrombotic condition. We also had a condition in a post-splenectomy case. Usually don't operate on trauma. Maybe conservative is the main treatment measure. And in a tropical splenomegaly variety of cases, they are very less coming to our center. So in one case, it was referred, like you said that, see the expert work up and send it to you. We believe on the expert on sending that it
Mm.
has been referred for surgery, right? So I also believe those people that who advised hemisplenectomy, and more of the workup was simple actually for me because bone marrow biopsy was normal and it was like not CML and all those things. Moderate splenomegaly was then symptomatic. But just post-op, what happened is next day platelets rose up, but it was too much. I mean, 7 lakhs around. And on the third or fourth, when we were just going to be discharging this patient, she was from out of the city. So he had some acute, maybe MI or something like acute abdominal condition or something like that, which we could not diagnose because he went into the arrest and all those things. So that made me think about the condition, like what procoagulant condition he had, or maybe the increased platelet. There I was helpless, like what to do when you find too much of increase in the platelets in the post-op period. Maybe in your case also, those pre-operatively going on immunosuppressants were helping in preventing the these uh,
Thrombocytosis
yeah,
post. Okay.
antibodies and all were keeping checked because of those I think immunosuppressants. So that is one lesson. I mean, but that's a total hematological thing. We
Mm.
are like we are helpless. We are surgeons. We don't know much about it. Maybe some co-hosts can put some light on that. I'm not aware.
I think
Dr. Kumath and Dr. Vibha have their hands raised if they can make their comments. Dr. Gomati,
Yes, sure.
Dr. Vibha.
Yeah.
Yes, so I just wanted to make a comment that, am I audible? Yeah.
Yes, ma'am.
So we had, as far as platelets are concerned, up to 10,000 they manage medically. And I have worked in Nizam Institute where I think I have done maximum splenectomies in emergency for ITP, and they were commonest referrals from the hematology department. And the other thing which I wanted to put forward is when the platelets are rising in the post-op period, there is a guideline. We as surgeons, we generally don't follow that guideline, but it shows that once the platelets are above 4 lakhs, you should put them on antiplatelets, and they need to be on antiplatelets. We work more on portal hypertension, so we don't see the sepsis also, and they insist on giving prophylaxis, the vaccine prophylaxis. And the other comment which I wanted to make was about the post-op complications which Gayatri had. It's not related to the splenectomy or ITP, but I just wanted to share one more such case. I'm sure many of the GI surgeons would have encountered this, and this was way back when I was training. That time, during the training period, we've had enteric perforations, and they are so difficult to manage. A young boy, a 6-year-old boy, he was operated elsewhere. He had enteric perforation. He came to our unit in Gangaram for a specialized care. And this fellow, he was with us for more than 2 months. He had multiple perforations, laparoscopy, and spontaneous perforations. We were so helpless, and Dr. Nandi used to ask in our rounds for opinions because we had exhausted everything. We had intubated the distal, proximal feeding, distal feeding, enteric, TPN. Ultimately, the patient did not survive because this is the downhill course. So I don't agree that re-explorations are bad. I think we have to do whatever it needs to make the situation better. And every time we may not win the situation. But yes, I agree with Gayatri's other introspection about being more prepared. That's it from my side.
Yes, ma'am. Thank you. I think you have added important points in the discussion. So another point I like to discuss, Dr. Gayatri, regarding those
And
venous.
Dr. Gomati is
Yeah, hi.
waiting.
Sorry, I couldn't unmute earlier. Gayatri, brilliant presentation, Gayatri. It takes a
Thank you.
lot to be able to come out there and, talk about a patient whom you lost and had a difficult course and draw conclusions from that. Just a couple more things in addition to what you said. I think very often when we run into complications, after a point we start getting defensive. I think, especially in the early years, I think that's something we all should consciously get out of. Rather than getting defensive, talk to more people. I'm sure you'll get a lot more ideas, which after a while, you're in like a dark space. It's very difficult for us to start thinking tangentially or in a brighter perspective. So instead of getting defensive, talking to more people definitely helps. That's, I think, one very important lesson, which it is not easy, but it has to be done, I think. And the other thing I felt was, you know um, get people from, sometimes even from non-related specialties, to start thinking about it. Sometimes you get brilliant ideas from them. Physicians sometimes, this is something I've experienced, that when physicians, you tell them, they come out with absurd ideas because we think specifically from the surgical standpoint alone. For them, surgery is a technical job, so they would come up with some idea which is like, we wouldn't have thought about it because we're so tuned to saying, okay, this is can happen only this way. I'm talking about, when I do my renal transplants, nephrologists have this tendency of staying in the OR. Hepatologists don't when we do liver transplants, but nephrologists stand next to you throughout. And
I envy the renal surgeons for that.
yeah.
Thanks, ma'am. Thanks for important inputs.
But it's very interesting because they tell you ideas which sometimes during complications you wouldn't think about at all, because for you this, come on, technically is not possible, but for them it's 1 plus 1, or why don't you just sew this like this. It used to irritate me, but then now I enjoy having them around, because when there's a trouble they will think out of the box. So I'm just throwing this, because when we need ideas, it can come from anywhere. So we need to open up when we have complications. Thanks, Gayatri. Thanks to all of you.
Thank you, ma'am. So Anyone else wants to add?
So I would like
Shruti, your
to
voice is breaking a bit.
invite Dr. Rajiv Sahai. He's put a. I would like to invite Dr. Rajiv Sahai. If he can please unmute himself. Manpreet, can you please unmute him
Yeah,
and
absolutely.
share
Good
his
evening.
thought? Yeah.
Right, good evening. I'm a general surgeon working in a government hospital in Delhi. We do a lot of splenectomies, a lot of bread and butter surgery. We do laparoscopy also a lot. Uh, my biggest concern is that my biggest asset during when I get caught in laparoscopic surgery is to call someone, what we would call as visual assistance. Someone just comes and just says, okay. So that really helps a lot. That takes a lot of load off the surgeon, especially when there's bleeding, there's a red out somewhere, and you don't know what to do. And another thing which I find is very good is that you insert a piece of gauze piece, and just pack the whole thing, leave it for about 10 minutes, and then come back again.
I fully agree. I fully agree with your points.
Thank you, sir, for those comments. Just one point which a few of us surgeons, including Dr. Puneet, whom I'll invite to pass his comment, is about the fear of re-exploring. At least, it should not be just the number of re-explorations, it's the intent and, probably so in this case, or in any case where only 20 centimeter of proximal bowel is left, it's quite natural for anyone to think it's better to do a primary anastomosis, because it's so difficult. Especially Gayatri was mentioning, it's a very obese person, so even if you do a stoma, it's likely to retract, and all of the complications will be much higher. So but in general, because there are so many other junior people who are also joining here, we would like to clarify that probably we should not fear just re-exploring, but then we should also be acutely aware of what we are doing in that re-exploration, and whether we are likely to benefit the patient or further worsen the patient's condition. And in this era of IR, is there a way of doing it via less invasive techniques? Other than that, probably not just the number of reacts is, the point which I'm trying to make, which I think Gayatri and Dr. Monica would agree with. And I
Yeah.
welcome Dr. Puneet to speak more on this, or any other comments that he would like to make.
Yeah, I think I completely agree with you about the re-exploration bit. I think there's a golden period for re-exploration, which most surgeons tend to miss actually, because initially we are in denial. We don't want to accept that, and this feeling that the patient is going to worsen after. I haven't seen a single patient dying of re-exploration, but I've seen, in double digits, patients dying for lack of re-exploration at the right time. We do end up doing too little, too late. Too much dependence. So somebody who's just a little sick, IR is fantastic. Somebody who's too sick, IR is fantastic. But it's that golden middle which is the best for surgical salvage. So lots of times we are worried about a negative re-exploration. I don't think even that should deter us. So I mean, I'm not suggesting that you re-explore every patient, but before you sort of throw in the towel. Re-exploration is a very good method, A, to teach us, B, to salvage any, even if you think it's very likely going to be, negative, somebody who's already on a ventilator, already on all that, it's just a few stitches more that you end up using. I can remember so many patients who were saved by timely re-explorations. So I think that should not deter us. I'm suggesting this is a proactive measure, not because I feel every case should have it, but we tend to avoid, and I see the cardiac surgeons very good at early re-exploration. So in the timely interval, we get it. In mesenteric ischemia, I find it invaluable. It's, you do an anastomosis, you are not sure, go in 2 days later, because by the time the sepsis cascade hits, as a second hit, the patient is lost. So if we find we can, if initially we thought it's going to be a short gut, the patient won't tolerate it, you end up doing a salvage anastomosis because you want some continuity of the bowel, even though there's a chance of a leak. But you go in again 48 hours later, if it's not leaked, you can just look at it and come out. Or in mesenteric ischemia, where the bowel is looking dodgy. Earlier, we used to say, if in doubt, resect. Now, the clear adage is, if in doubt, re-explore. So, in mesenteric ischemia, I think it's been a fantastic tool that I've found. There's one patient, somebody balked at the fact that there was 6 re-exploration. There's one patient from Gujarat who'd come to us in Kerala with, we did, I think, close to 11 re-explorations over the course of a month. And I was surprised by the patients. Every time I went back to them, I was surprised that they said, no, we have complete faith. We can see each time the patients actually improved. They still send me every patient, whether I'm in Faridabad or Cochin, that family still sends me patients from there. So I think this fear we should not, I just wanted to stress that bit. About the platelet count, I think we have a lot of agents. So what I found is, don't, like what Gayatri very elegantly suggested, that don't think you're a master of everything. So we used to get a lot of splenectomies from, a lot of variety of conditions. So each of them have a different problem. So, so our hematologist used to send us a very bright guy, and I would be scared at 10,000 or something operating. I'd say, give it before. He says, no, keep the platelets for after the splenectomy, immediately after. I will bump up the, platelets by a variety of drugs. If it's ITP, then, give one of the steroids or immunosuppressives. Then these, what do you call them? Those platelet stimulating agents like L-Trompobag and all those. Even there's some thalidomide analogs also, which can help bump up for temporarily. So those are very useful. So get your medical colleague involved, and they can push it up very safely before surgery. And we keep all these platelets reserved for the surgery right after. So this, many medical IR people, they want a certain platelet level before they intervene. I'm not sure for surgeons that's the right thing, because, we have the thing in front of us. And again, we don't need to avoid laparoscopy since it's less invasive. You just need to be careful about putting the first port and don't get a bleed right there. But because you have a less area of trauma, doing a careful and slow thing might actually be better. But like Gayatri showed that, early conversion is very, very, very important. So for all those things, I think a lot of lessons in this particular one, and get help. Yes, not only, Rajiv, I think, mentioned get help. I'd go a step further. My colleague in Cochin, Sudhindran, he sort of made me realize that it's not just when you re-explore, a lot of time the patient has this worry, are they covering up for something? So he suggested that so he would get in a colleague to actually, have a look whether you need the re-exploration and also help in the re-exploration. So, you get a fresh set of eyes who don't have your prejudices or, all that thing at the back of your mind. So they actually help you get a fresh pair of eyes and brains to look at the problem. It helps you in the, it doesn't look like a cover up. And the guilt feeling completely goes away because you feel that and I've seen the most senior-most people, Dr. Kaushik, SP Kaushik, when he had a biliary injury, he's given lectures on biliary injuries for years and years. When he had it, he actually called a colleague to do the so we need to have that kind of maturity as well. I think I've spoken too much.
Thank you, sir. You are
Thank you, sir.
always welcome. So, just the point on where you're calling the colleague intraoperatively, also because you don't want, I mean, one is a fresh pair of eyes to get a different perspective, but is it also that the colleague can help you in counseling the patient? Dr. Puneet?
Yeah, sorry, it wasn't allowing me to unmute.
Oh,
Yeah, absolutely. I think when you tell anybody, so my colleague here also in Faridabad, Salim, he will actually go and tell the patient, I'm getting my colleague to have a look at this patient. So the patient automatically feels the best has been done for them. They do feel, even in a re-exploration, that everything that was possible to try. So even, to stress again, even if you feel it could be potentially negative, you don't want to miss something which is salvageable. So that's the key thing. So they definitely do help in the counseling of the relatives as well. And I've felt the relatives are actually more comfortable, and this worry that, oh my God, they might go to my senior colleague or something, doesn't happen. They still maintain that first line of contact with their primary surgeon. So I think if we are mature about it, we're not worried about it. It's been it's a good thing to share that responsibility. There's a very famous saying in this book, Doctors by Eric Segal. I don't know if you guys have read it, the love story guy. So it's a fantastic. There's a thing about the surgeon when he's successful. He goes with chest thumping to the bedside and says, "I did this. It was a very difficult, and I could do this, and I." It's all about the I. And when there's a complication, he takes the whole team, and we tried our best. So I think if we have that approach for both, I don't think we'll ever, it's very easy to shift between those.
Yeah, I tried to read that, but it is I think, very thick book, and I did not finish it. So,
Okay, we are talking about splenectomies and antiplatelet, like, aspirin, and there's also some discussions on hydroxyurea. So I see that Piyush sir is here. He probably has the most experience in portal hypertension surgeries, and, I would welcome his, views on this. This might be a ITP splenectomy, but then we still want to know your thoughts on this aspect, sir. Dr. Piyush?
So Dr. Pata Radhakrishna is also here. Maybe we can hear from him in the meantime till Sir joins.
Pata sir?
Firstly, I'm surprised that all the videos are off. For any particular reason, I do not know. But then, yeah, no, I think it's a very sort of interesting presentation, and as expected, Gayatri speaks so well. Very good vocabulary. But I think she's taken too much pain than is necessary, because I think that is a very vulnerable age that she got into this. Firstly, she was a postgraduate trainee. I'm sort of jealous that she was doing lap splenectomies in emergency independently, and that too confidently, and whoever is the boss sort of let her do. I mean, that speaks volumes about her ability. But having said that, see, the morbidity and subsequent mortality is nowhere related to the initial surgery. I mean, the splenectomy can always get converted, and that's not a big deal. But I think she's taken too much pain than she should actually. Then on, whatever happened in terms of superior and thrombosis, bowel ischemia, redo, all that, I think the senior consultant have gone in. But I think this she got bitten by this so much that she suffered a lot, and she continued to do so. Yeah, the interesting part is, no, as super specialty or PG trainees, we've gone through these where we worked in units. There's a 25% emergency operating mortality. If we all have to go through this, it's very difficult to survive. Imagine if this happens to someone who's leading the unit, or who's, an independent private practice, or working abroad as an independent consultant. I've seen this happen, and so I can see this. But I think it's very, very, good on our part to own moral responsibility, although it's not in place because whatever happened is non-technical. So that's something I want to comment on. And secondly, she made I think the pain is more because the patient is young and is a sort of a curable, say, it's not a fatal disease, and that's what I think possibly she's affected so much. I think all of us would have had patients like this at that age group, which hurts us. But I think there are many lessons learned, which is she's put out very nicely. There's so many technical issues involved, and often I wonder when we get a next patient like this, we really do not know. Over the years, after being independent, you sort of become mentally strong. I wonder whether that was a government institution or a private institution, because the whole sequence changes so much. Because if it is a government institution, it's a little easy because the boss can speak and get over. But it's a private institution where money has to spend. There are many occasions when I wanted the sun not to rise, because I don't want to see someone. And it's very difficult to deal with patients, especially when they're trying to spend money. More and more people gather, more and more new people come in, and put you under so much stress, and at some point of time there can be a threat of physical violence. All these one has to go through. I think it's good that she's realized that how morbidity can really affect somebody at this age. Secondly, the thing of YouTube, because I was in Kolkata recently, then for that IHPB, and I see that majority of the audience are senior surgeons or seasoned surgeons. Youngsters are not there. And when I discuss with a couple of friends, they say, no, they would know that all these is available on YouTube. They can always see. But as Gayatri rightly said, that whatever is shown in YouTube is all, very polished and tailored material, and seeing that is no way going to mature anybody, a trainee surgeon, and it's very important that we should be in the thick of action. I'm sure Gayatri would have lost a lot of sleep over this patient, and even now she may be getting some very bad dreams about it. But one I think that will make you stronger. And interestingly, that made you take up a super specialty, and in super specialty you'll see much more morbidity, mortality, and in even sicker patients. Now, I think there are many things to learn from this talk, especially for the younger generation. And I think it's a very well presented case, Gayatri.
Thank you. Just to
Just
clarify, sir,
one.
I was post-MS. I was a junior faculty, so I wasn't exactly a lucky trainee, but yeah, I was a junior faculty in the department. It
So
was a
then,
private medical college. Yeah.
then the trouble will be a lot more. And so you are directly responsible for the patient care, right?
Yes.
And there's a boss though, but he is independent of you.
Yes.
Then that says it all, and that definitely. And I thought you are a PG trainee and
No,
suffered
I
more
didn't
than
have that
what you should.
umbrella, no.
Yeah, this can happen anytime, especially when the small ball gets into trouble. There's nothing like it. And we've seen in the AIMS under Dr. Nandi, we've seen so many patients like this, and multiple fistula. You have a peritoneal cavity with multiple small ball fistula is very difficult. If it's liver, pancreas, this, that, and that is okay. Small ball is a very dangerous area. But I think it's all good learning, and it's chosen a beautiful case for this. We also should understand the first point you said, that we should also know the pathology and physiology behind, and we do sort of good research before we take up patients like this, because not all patients are straightforward.
Okay.
But you can show a video now. It's allowed.
Oh, my video.
Yeah.
And then I was wondering why everybody is,
No, I think it's distracting for the
You know
ladies.
why?
We thought the ladies are distracting, but looks like the ladies think it's distracting. It's
No,
a good
I don't know,
reverse.
but there may be a policy. I really do not know, because everybody is hidden, unlike the marvelous medicine. Vidya must be there. Is still there. I just want her to make a comment on Vidya, if you're there.
I don't see her name here,
No,
sir.
she's not there. She's not there.
Yeah.
So just one point I wanted to make about the, when the platelet counts go up after splenectomy, it's important to realize that most of them tend to be, it's a reactive thrombocytosis and can come down by itself. So only if you're seeing rising trends do we need the antiplatelets. And beyond a certain level, I forget, I'll just look up the guidelines, put it in the group. I forget whether it's 10 or 20. Beyond a certain very high platelets, they are ineffective platelets, so you don't need to give antiplatelets, may be counterproductive. So and you increase the bleeding risk. So I think because it's thrombocythemia, those platelets are ineffective. That's why the marrow is trying to actually increase it. So beyond a certain one, we shouldn't give it. And I think that is there in one of the guidelines. I'll try and hunt it out while the rest of the talk happens. But just to say that be careful about very high and just keep your hematologist in the loop.
And about that, it's also different for non-portal hypertension splenectomies and the traumatic splenectomy, ITP splenectomy, etc. Usually in EHOs, if you've done a splenectomy with or without a shunt, and then if the platelet count is increasing, in AIMS we've even had a threshold of, I think we used to go and start consulting Dr. Piyush around 7 lakhs, 8 lakhs, saying that it's gone up. Should we wait? Should we start? And then I think his threshold was slightly higher, like 12 lakhs, 13 lakhs, and then, based on many other factors. And I think, in this, there's always something which, whatever the guidelines say, there's always that personal experience which, will nudge us towards following which guideline we want as well. Because just incidentally, just today, for EHO splenectomy, at 4 lakhs platelet count, we started ecosprin in our unit because of a previous experience, which was very similar. I think Gayatri would know that case. So, I think there's a lot of things to learn from this kind of format where we are not learning from, just textbooks or subject discussions.
So I wanted to just add that this antiplatelet usage, even we were not accustomed to, because Dr. Nandi is totally against antiplatelets in the post-op patient for shunts. But when I was working in Nizams, there was a young female. We had performed a shunt procedure and her platelets were just escalating. And as usual, we hydrated, did not start antiplatelets. And then we found that she had renal artery stenosis. Then it progressed to, she had arterial thrombosis. And that is when the hematologist was consulted and they started with all these guidelines. I'm not too sure about the high platelet one. I'll have to read up. But then I also read guidelines and they have a separate guideline for ITP and hematology patients where they always give ecosprin low dose above 4 or 5 lakhs.
And there should be a healing mechanism. I don't know how we all deal with it. Somebody should be confiding in somebody who's a spouse or a friend or whatever. These things are really, really traumatic. They're days together, you don't feel like sleeping, don't feel like eating, don't want to show your face. That matter, you want to take leave. And then I often wanted my patients to die on a Sunday, so I need not see any relative. These things happen, especially when you're dealing with very, very sick patients. We all have to have some special healing mechanism, otherwise it's going to be very troublesome.
Yeah.
I think one of the best healing mechanisms is talking to the patient itself. So, like Pata said, initially I would always try and avoid, but I realized that if they have trust in you and if you're holding their hands all through the problem, they actually understand the issue and they give the support. So I remember it's funny that you talk about splenectomy. I wasn't aware of the adverse effect of combining a splenectomy with a colectomy. So there was an ulcerative colitis patient who also had ITP. So, while she had come in, fulminant colitis, we were going to do a 3-stage surgery. We removed the, in GP Pant, I removed the entire colon. And we used to do an ileostomy mucus fistula. But because the platelet counts were very low, so, somebody says, why not do a splenectomy? And I actually did that also. She had a bad outcome, from that thing. And actually, when she, she had an escalating series of whole OPSI kind of a situation. All through the guy, her husband, actually, when she died, I still remember he held me and said, "Doctor, you tried your best." So I will never forget that because that's the only patient I had no guilt, even though that was one where I should have felt because, later when I read that adding a splenectomy in any bowel resections actually adds to the septic complications. So I wasn't aware of that before. So despite that, if the patient has trust in you, that's one of the best coping mechanisms. But I think Pata's spot on, especially for ladies. I think now it's much easier because you have other colleagues. But when you feel isolated, that's the time what I notice is many of them want to take that, on themselves rather than wanting to share, because this worry that am I going to be blamed for this. So I think don't if you don't let gender come in the way, you'll not never have a problem. You're definitely going to find some woke people around you, and if as a habit you do it when you discuss all the good and bad in all the coping time, also you'll find it a fantastic coping mechanism. So I think you should do that more regularly. And I think Pata's spot on, having colleagues doing it or another department or a sister department. I think we all need.
And actually, frankly, I saw all the patients' relatives go to him, my number two, and talk to him all the time. I'm sort of ignored completely. He takes hold of the situation, and he beautifully manages the whole thing, including death summaries, this, that, and the other. So I think it's very important. We all should have one very good, next immediate colleague who will help us out.
That's a very good combination, probably like a good cop, bad cop combination.
No, it can't be bad cop too. Good cops are the better cop. That's.
Okay. Any other comments from anyone who
Dr. Uma had a couple of questions. If she wants to discuss them on the chat, that were being discussed on the chat regarding the use of hydroxyurea. I think there was a discussion.
Yeah, I was wondering, we have never, I've just read about it. We have personally never used the hydroxyurea. So I wanted to know your experience if anybody uses it regularly.
I don't know if it ever works, especially if you have this sort of a thrombocytosis with a massive superior-mesenteric vein, portal vein thrombosis. I don't know. I mean, I think it's more of a medical area where people just try it out, but whether it really works in these sort of life-saving, life-threatening situations, I really do not know. As Dr. Vibha rightly said, that you had seen so much in the All-Indian Medical Science of Nandi's unit, but that doesn't really seem to do any wonders.
So I'll tell you again, this is from Gangaram. So we had one patient of Badkari, and we performed, he was already on hydroxyurea pre-operatively. And then a shunt surgery was performed, and he had very high platelets, and they have this polycythemia vera. So that was the cause. And he was put back on hydroxyurea. So that was as a medical management, and I read as a surgeon because, of course, I didn't have any such exposure. So that was one patient where I remember instead of antiplatelets, he was put back on hydroxyurea.
So hydroxyurea is, especially for polycythemia vera and essential thrombocytopenia, it's a proven modality. So ideally in these conditions where if we are suspecting a procoagulant condition, it's better to evaluate them prior to the surgery when they are not anticoagulated and, take the essential steps for that. Okay. Anyone else? Anything to say?
Dr. Jasmeet Singh had his hand raised. Do you have a question, Dr. Jasmeet? Okay, maybe it was by mistake.
Okay.
Yeah. So
Just wondering, I think.
Sorry, sir, please. Sir, you unmute. You muted.
So a lot of ladies who would benefit from these. I think you should share it in other groups as well, so that I think it's a very good coping thing when you see so many other problems happening and all that. So I think you should send it to other people as well. Not just the focused GI liver group only. I think everybody will benefit from a lot of the general topics, no?
So this is being shared in Learning General Surgery as well, and I think we get a lot of.
There should be a write-up, in addition
Yeah,
to
Pata is
this.
very good at that. You should have a write-up. It's a good idea.
Yeah, if pay me, I'll do. Now, see, the other thing, Puneet, I don't know, but what happens whenever there is a morbidity and a thing of this nature, the management will call you.
Yeah.
Whoever the director of medical services, they want an explanation. One, two is they make you sit with the patient relative team and have a conversation. That's the most difficult thing, I'll tell you. I mean, the management should tell the patients that, see, my consultant is the best consultant. He does what is best for him. Bringing people together or giving an explanation, I think these are all the things, the honorable members should
This
understand
is
that
the
these things
corporate
happen.
culture. So I
I
think
think I don't think it's a bad culture, because I have not seen a problem come out of that. I've only seen solutions come out of that, because the feeling that everybody's talked to us, so especially something like this where the hemat or onco doesn't have time to come, if the admin people do. So what we have done is, our ICU, there's a room outside the ICU which has got a camera as well. So it's on continuous monitoring. So everything is being recorded there. So whenever we find this anything awkward, we actually take the patient to that room, and that's why we do the MDT counseling also.
Yeah, we also do the MDT, sir.
So it's I think, yeah, Gomti, isn't it? So the transplant particularly, it's anything could go wrong. So I think it's I have found it a useful mechanism rather than being, it looks like we are put in the dock, but I don't think so. I think if you tell them these are problems which happen, and this has happened, none of them have actually the multiple people being there has not made, I don't think we should feel awkward about it, because it isn't, why we try to take everything on ourselves, I'm not sure.
No, Puneet, the thing is, I totally agree with you that, it puts everything in black and white, it's easy, but, quite often, if the management talks to you that, see, that's your problem, I'm not going to do, I was asked to put people together, that's what I'm doing. Because, we have seen managements of both types, the ones who try to sort of, make things very clear, and the ones who say, I'm only a witness, it's between you and your consultant.
Should not
Yes,
be
I
a
think
delay.
more than the money, we should be looking at what kind of management we want to work for.
Yeah, true.
Managements often use it as a pacifying mechanism for the patient relatives. I think that's what Patta sir is saying. It should not be so. It should be with the actual intention of, actually helping the patient. Yeah.
most of the times these are recorded because they want to put it on record that any complication or any downhill or prognostication, the management along with the clinician and the patient's relatives, they are on the same page.
Agree.
So I would just like to add that I think it's not just the women, but like every surgeon goes through the same emotions and the same sadness, and uh, even the men may not have somebody to share it with. So this is just an open forum for everybody to share their
No,
problems.
I don't know with this literature to say that women take it much more closer to the heart and try more than
There is
men do
actually
in this area.
literature.
I don't know, really, frankly.
It is there. Uh, I was just doing a literature search for an article. It does seem to be there.
So that's very much related to the positive points that we talk about, right? That they're more caring and I feel like all of these things are social conditioning. So I think the next generation of, the sons who will grow up to be doctors, probably will have the same traits, hopefully.
So actually, you're absolutely right, because it's my son who tells me that you should not be taking this personally. You need counseling, otherwise. So what you're saying is absolutely true.
I think at some stage in our career, someone has to tell us not to take it to their heart, because I have also experienced it. I was just a trainee, and you have a patient who has a post-op leak and he doesn't do well, and you feel so bad about it. But someone has to say that, okay, it's okay to have complications. And you work hard for it, but you can't be feeling sad and taking yourself away from the main motive of working for the patients.
So I think we all have to be there for each other and support through that. So I think if you do it for somebody, they're going to do it for you, definitely. So I think we need to instill. Yeah.
WIGIL
WIGIL
can
is a
take
fantastic
initiative.
topic, though.
It can take an
Absolutely.
initiative, and for all of you, I'm sure all of you will face some trouble or the other every now and then. Then you have to get back to the group and discuss and be friends. There can't be a better network than this.
Absolutely. I think Pata's spot on, because, when you've seen everybody having gone through some complication, the I'm not alone kind of feeling is a fantastic feeling that I'm not the person responsible. I don't think we should take anything personally that if it was somebody else. I've seen a lot of times when a very senior person did something which was didn't go off well as well. So it's not I don't think we should ever feel whoever's there on the field has been the best. I have seen that. I wouldn't question that. I would give suggestions after that, and many of them may not be the right thing. So it's just, I think what we need to do is deconstruct as to what are the options. Ideally, if you do it before, is much better. But at least say that these are the options which we could have done, and that helps the cohort. This what Gayatri's thing has helped is, I think, the cohort. Even she was brilliant in that first meeting of, I'll never forget. I think I met her properly for the first time. That time was in the first meeting in AIMS. And I told Sadiq at that time, I don't know, I said, the clarity of thought is so good. I think we need to have that. If it comes out, I don't think you'll keep it inside you.
Thank you.
So, a short anecdote before we end. I got to know details of this talk a week back when we were trying to do the write-up and share it. And I had a lap splenectomy planned the next day. So I then actually, we did use this network, and I called up Gayatri that, yes, I have a lap splenectomy. And since you're having this talk, let's just go through what could go wrong. And I think that really helped me. I did go back and check the history. Did they have anything else, APLA or Evans syndrome? A couple of points in laparoscopy, which I think really helped me. So thank you, Gayatri, for that. The patient is doing really well, by the way.
Okay.
No, I
He
think
had
we
a
should
sense
get
of
together.
peace too. She has
Yeah,
a
get together
sense
all
of
these
peace to
patients.
Gayatri as well.
Okay, we've been talking for more than an hour now. Any closing remarks, Gayatri? And then a small announcement till, I think there are 17 people here. So just that we've decided to have a guest talk this month. Usually this WIGIL webinars will be the first Tuesday of every month. We'll continue with that. And this time, the third Tuesday of this month, we are having a guest talk. This time it's going to be by Dr. Sadiq Sikora. Please do log in for that talk as well. Gayatri, would you like to make any closing remarks?
At that time, like Dr. Bhatta said, it was a harrowing thing to go to work every day because of all these emotions, helplessness, guilt, and all that. And what really helped was, like you said, support at hand. And going ahead, forums like these are also, it's refreshing to realize that you can discuss openly, I think, without judgment. That's a very important thing. Again, like Dr. Puneet said, to know that you're not alone. So that really helped. And thank you for this opportunity. This is just one of those, things that weighs in, and one of those experiences that I will never forget. I'm sure everyone has that one case. This has been my one case thus far. I hope I don't have another case like this ever, but I'm happy for the opportunity to share this, and thank you for the wonderful discussion. Yeah.